As the leading professional association dedicated to infection preventionists, APIC provides the resources, thought leadership, education, and comprehensive training to help you protect those in your care. More than 15,000 IPs globally depend on APIC to help them develop and manage top-tier infection prevention and control programs. Join APIC today and unlock exclusive benefits such as educational content, access to cutting-edge research via our journal, and networking with peers to propel your career to new heights.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Lerenza Howard, and my preferred pronouns are she, her.
And I'm Kelly Holmes, and my preferred pronouns are also she, her. Hey, Lerenza, how are you?
I'm doing good. Starting off the summer well. How about you?
Yep, doing good.
We have an amazing guest, Allison Zelikoff. She is a nurse manager for occupational health at Fred Hutch Cancer Center in Seattle. They are a cancer research institute as well as a patient care center. Welcome, Allison.
Thank you so much for having me.
Hey, Allison. So is Fred Hutch short for Fred Hutchinson, or is it Fred Hutch?
It is. It is short for Fred Hutchinson. Absolutely. Okay. The founder is the brother of the Fred Hutchinson you were referring to.
Okay. Well, I love that. I love that. So I'm going to, start right off, and I'm going to hit you with a 2-for-1 question. So first of all, could you tell us a little bit about the history of the occupational health field in healthcare? And then I'm very interested to know, how did you get into the field?
Yeah, absolutely. So some quick facts related to occupational health and occupational health nursing. So in 1970 is when Nixon actually signed the Occupational Safety and Health Act. It was enacted in 1971 with a goal of ensuring safe working conditions for all people. And what it did really is put responsibility on employers for minimizing hazards and promoting safety. And the protection of workers' rights were expanded and strengthened again in the 90s to ensure things like falls and bloodborne pathogen exposure, toxic substance exposure, and some other hazards are monitored and prevented as much as possible in the workplace. So in regard to the specialty of occupational health nursing, it's been around a really long time. So dating back to actually 1888, there was a nurse named Betty Mulder, and she was hired to care for the coal miners and their families in Pennsylvania. And so the actual recognition of the specialty happened in 1971 with the founding of the American Board for Occupational Health Nurses, that's ABOHN. And the first certification exam was actually administered in 1974 in Florida. So this organization is still the sole certifying body for occupational health nurses. Overall, so continuing on occupational health nursing, our field focuses big picture on prevention and population health for workers. So we're aiming to minimize hazards in the workplace. We respond to events to minimize the harm in the setting of injury or illness or exposure. And we engage in health promotion through vaccination programs, education and training, and then psychosocial support in a really demanding and often really emotional environment. So that's just a little about occupational health and occupational health nursing. But as far as me personally and how I got into the field, it was really a lot of that psychosocial support piece. It's a big part of what guided me into this field. So I was actually unexpectedly engaged in Occ Health during grad school when I was getting my Master of Science in Public Health and Community Health Nursing. And I got placed in a clinical rotation at Harborview, which for those of you who are not familiar with Seattle, Harborview Medical Center is our level 1 trauma center. It's for a large region in the Pacific Northwest. And we're really a mission-based public health hospital, and it serves our most vulnerable population. So people coping with severe mental illness or addiction to major burns, traumatic injuries. And during this time, when I was a graduate student, I got guided through my first publication by our director of infection prevention and control at Harborview, who really is one of the people who really most inspired me in my career to this day. And I spent my initial years working here as a nurse, providing patient care in our shelter environment, serving homeless patients, worked as a sexual assault nurse examiner in the emergency departments around the county, and then as a case manager for people with multiple uncontrolled comorbidities. So eventually I moved into leadership, and I provided a lot of clinical operations management for other service lines. And I really learned so much during my time at Harborview. And when I saw the occupational health program leadership position opened, I applied because I really wanted to take care of my colleagues, the ones that trained me and educated me and cared for me really during my time at Harborview providing direct patient care. And so when I took the role in February 2020, we all know what happened immediately after that. It was a really, really challenging time in infection prevention and Occ health. So I'm sure none of us on this podcast probably had much sleep between 2020 and 2024. But it was, and despite being incredibly challenging, it was simultaneously just totally engaging and motivating in regard to preparedness, regard to supporting and protecting our health workforce. So, yeah, I stayed in it and I really love it.
Yeah, thank you, Allison. That was such an amazing response and in-depth response related to your work. So I'll share with us, how exactly does occupational health partner with infection prevention? And then in addition to that, explain to us the importance of this partnership and exactly what does that look like for you?
Sure. So I would start by answering that by noting our practices and our protocols and our policies in infection prevention and occupational health. At minimum, we just impact each other. But in my experience, our roles are often dependent upon each other's work. So IP or IPC, depending on where you work, would be referred to. You're really aimed at patient safety, of course, with a lean towards preventing patients from exposure to and acquisition of various pathogens, where Occ Health is a complement to that. So we focus on employee safety with a lean towards preventing employees from being exposed to these things and other hazards in the workplace. So really, ideally, our efforts aligned would create an overall safe environment for patients and staff so that people can safely provide and receive the care they need. And I think that we are excellent consults for one another and really rely on a lot of the same information and data to guide our practices.
Oh, yes. I love that. I think that's such a good description. In my practice, I have worked in several hospitals and seen kind of a gamut, I guess, or a wide range of relationships between infection prevention and occupational health. And when I first started, I was also very fortunate to work with one of the most amazing occupational health nurses, and she taught me so much about safety in general, chemical hazards, and then employee safety as well. But I've worked recently in more hospital systems where it does not seem to the connection between infection control and occupational health is not as strong of a connection. So, what do you perceive some barriers to be that may exist between the IP role and the occupational health role?
Sure. Yeah, there are plenty of barriers. And I would say, in my experience, the biggest barrier has been administrative and financial structure in institutions. So my opinion, again, is that these disciplines function best when they're connected and they're functioning under the same leadership umbrella. And IP, IPC, and Occ Health have varying priorities, but overall, the same major goal of creating a safe environment in the face of healthcare-associated hazards like bloodborne pathogen exposure, respiratory virus exposure, lab safety, et cetera. So when they're separated, I think planning and communication and policy development gets fragmented and can be sort of confusing. And it can be really challenging to quantify the quality of the work, to quantify prevention. So we, occupational health and infection prevention, we're a cost avoidant resource, right? So we're required to exist for the organization. And occupational health and infection prevention really, they don't bring in revenue. So this makes getting buy-in from healthcare administrators like really challenging when it comes to FTE and resource allocation. And really those are the largest barriers that I see in the environment.
Yes. So you say under one umbrella. Does that look to you like, sharing a medical director for both like the infection control and occupational health program, like the same chairperson of the infection control committee type thing? Or are you talking about, infection control reporting up through quality versus maybe occupational health reporting up through HR?
Yeah, I think it could be any of those things. I would recommend the departments fall under the same leadership to any degree. So whether it's through first line operations management, like you have the same manager, you have the same medical director or senior administrator, however that rolls up, it still has an opportunity to align those priorities.
Yes, I agree. Very good point.
Yeah, and thank you, Allison, for that. So, of course, noting, going back to what Kelly noted, that's absolutely integral. And I think that, there needs to be additional conversations regarding this collaborative effort in bolstering our relationships, because I'm pretty sure many other IPs also have that experience, whereas they're not, so well intricately woven with their health partners, in addition to the fact that, some of the occupational health man-woman power at the facilities is now virtual and at some sites. So explain to us exactly how can we as IPs and the IP community work to bolster that relationship with occupational health?
Oh, sure. So, I think at, our foundation, like setting that structure for the two disciplines to work together is really key. So in addition to that reporting structure, as I mentioned, I think it's paramount that we really understand the differences and the overlap of each other's priorities. So I think clear outlined responsibilities with ample opportunities, tons of opportunities to come together and have conversations related to specific cases, to public health metrics, emerging public health threats, or other information that really informs our policy and protocols. So I think alignment in these two specialties and bolstering that relationship could provide clarity for our healthcare workers when it comes to how they can stay safe at work and provide the best care for their patients and their communities. And in my mind, this all translates to prevention, which is what we all want, right?
Yeah, absolutely. And one thing that your response just made me think of something, right? So would you foresee that there's a benefit in having occupational health, say, for example, in, at some sites, maybe the IPs conduct drill downs for their HAIs and, or, even as it relates to emergency preparedness, as you're noting for emerging infections and ensuring that we're adequately prepared. What does that look like to you as far as whether or not occupational health should be involved? And then there's that cohesive education for our staff to ensure that they're infection control guidelines appropriately, in addition to, measures as it relates to emergency preparedness.
Yeah, I think absolutely. So as far as drilling down in details and, bringing occupational health into discussions and things such as HAIs, I think is definitely important. I think it's important for occupational health nursing learning purposes, of course, just of how IPC functions and what their priorities are. And I think just general awareness of our staff of like what is out there, what is crawling around our facilities, what do we need to be concerned about? It brings a lot of context to the policies and the practices that we require our staff to do that are working on the front lines. So I think that is really important. And what it looks like for us, at least in our institution and other institutions, was regular meetings, regular conversations between IP and occupational health, where we talked about all of these things. It's multi-system, multidisciplinary discussions that are OC Health and IP. And we are talking about, preparedness for any additional or new novel pathogens that are coming. Conversations around trends we are seeing in HAIs and what that means for what our staff need to do to minimize the spread of these things. And there are a lot of considerations that IP might not recognize or Occ Health might not recognize. And it's exactly one of those things that I think informs all of our practices.
Thank you for sharing that. Do you
Yes.
think that, I know that one of the things that some infection preventionists noted, and it's included in the literature as it relates to, they've experienced barriers regarding staff, even, listening to them at some point during the pandemic, as far as it pertains to infection control guidelines, even wearing PPE just to ensure that they're protected. They resisted those things. Do you think that if there was much more of a stronger occupational health collaboration between infection prevention, that maybe we could have circumvented those issues?
That's a tricky question. I mean, it is possible. I think that there was absolutely room for more alignment on our messaging and our education, during the time that we were coping with all of these changes and all of the panic around us. I do think that there's a lot of personal decision making that goes into that as well, because we can do everything in our power to provide the resources such as PPE and the education, the information, the data, but people are still going to make the decisions that they want to make in regard to, am I going to put a mask on? Am I going to be careful when I remove my PPE? Am I in a hurry? It's, it still depends on that individual, but I think it's possible if we really from the beginning made it a priority to align our messages and the information that we provide.
I agree with that so much, and on multiple levels. I have a question just popped into my head. I was thinking about a meningitis exposure. So we had a patient come in, suspected meningitis. They did the CSF. We're waiting on it, kind of collecting the names of anybody who could have been exposed to the patient. And then we work closely with Occ Health on that list of, potential staff exposures. But Allison, how do you keep people in the ED who maybe did not have contact with this patient, who just walked by the room and they're like, oh no, I'm getting Cipro, and by the time that we all are like, okay, here we are, it was meningitis, we need to give Cipro to those who were exposed. And by then, like, everybody's already gone to the ED doc and gotten their prophylaxis. And you're like, oh, well, that wasn't necessary. And we're, possibly contributing to antimicrobial resistance. It's not good for you. So how do you deal with that on your end? Or how could we do that better?
Yeah, absolutely. So, I mean, this feels very familiar. I think that, again, there is that personal decision, and people absolutely have the right to go to an emergency room and say, hey, this happened at work. I'm scared. Can I, get post-exposure prophylaxis? I think the role between infection prevention and occupational health in this setting, is again to get together and really develop a comprehensive plan. So IP, you're going to reach out to patients. Occupational health, you're going to reach out to employees. And we need to do this now so that they get timely information, so that we can quell their anxiety, because the longer they wait for messaging, the more anxious they become and the more likely they are to jump to something that might not be necessary. I think what's really important in this setting is patience, education, and consistency. And that's really, for all of our exposure events, I think that is particularly important, so that our staff know that we have a strong relationship with IP, that we understand and, agree upon the same information and plan moving forward. And I think that's really what helps our staff feel safe and protected and cared for in their work environment.
That's excellent. Yes. Presenting a unified front, being consistent with the messaging. Yes. And having the staff know that we would never ask them to do something that was unsafe, and that their safety is our first priority to take care of the patients that are coming in. So yes, I love that messaging. Thank you for that. Yeah. Do you see, I guess, roles, or have you talked to individuals within your field that kind of have to wear both hats? They wear the occupational health hat, they wear the infection prevention hat, they split their FTE kind of between the two fields. Do you feel like that model can be successful, particularly, I guess, in like a smaller hospital, we might see that?
Sure. My initial reaction to a role like that is no, absolutely not. Yeah, like two
Right.
enormous
It's
bodies
a
of
lot.
work. How can you expect somebody to do that? But the reality is that this model of Occ Health and IP program administration is common in lower resource settings and small organizations like you're talking about. And they do overlap as stated, and they're very different. But the overlaps, I think, primarily lie in things like vaccination programs, exposure response, outbreak mitigation, emerging public health threats, and in addition to those things, the Occ Health team might work on other large bodies of work like respiratory protection programs, workplace violence, ergonomics, mental health. And then IP is going to have their own large body of work related to CLABSI, CAUTI, et cetera. So the scope is just so broad. And our responsibilities are really defined by different laws and different regulations, and being able to understand all of those and remember them and, design your workflow by these regulations is hard. So, that said, if this model is to be successful, I think through education and training in both fields, there is a possibility, and the objective of ensuring that both perspectives are represented in policy and protocol. I would recommend in this setting a big focus on building and maintaining partnerships with resources around you, as well as engaging other staff in the organization, from the perspective of you don't have to do it all yourself. And what I mean by that is, you partner with nearby urgent cares and who are trained to provide assessment of workplace injuries. Peer-to-peer vaccination programs, so our clinical staff in our environment vaccinating each other and other employees on behalf of occupational health. And those are really successful and commonly planned during influenza seasons. Third-party organizations exist to provide things like respirator fit testing, hearing conservation testing programs. And then things like remembering that things like fit testing and data entry, those things don't require a clinical license. There might not be enough funding to hire another clinically licensed individual like a nurse, but there might be money to hire support positions that can be engaged, and they cost a lot less than a full team of clinically licensed staff. So consider how you can be an interdisciplinary program and ensure capacity for problem solving and data analysis that you really need that clinical brain for.
Oh, that's excellent. I honestly didn't know there was a third-party option for the fit testing.
There are
down.
There are organizations that just do that.
That's awesome.
And you can bring them in to do that work for you. We also have a truck that comes here that provides our hearing, our audio testing for our staff who work in loud environments for our hearing conservation program. So it's really great. They just pull up and do it for us and send us the records.
That is fantastic.
Yeah.
A great way to leverage, the community resources. Yeah, that's fantastic.
So I'm curious, based on your response, Allison, is there any opportunity from the aspect of APIC to better cultivate and advance that relationship and partnership between IP and occupational health, and or, even if there's the opportunity in the future to possibly develop a dual certification?
Yeah, I love the idea. I think, our disciplines could really use some bonding. I think we acknowledge how much we need each other, but we could really, work together more and more consistently across all systems everywhere. And I think we have just a real opportunity to support each other and to optimize the safety of our environments. So in the setting of our healthcare system being so strained in staffing, I don't expect these combo IP Occ Health jobs to go away, despite the workload being enormous. And so I think I'd answer that by suggesting that APIC really dig into that overlap and identify ways that we can produce a curriculum that addresses both of these fields. So you have the CIC curriculum, and then you have the COHN curriculum, which can evolve to provide more nods to each other. This conversation could result in a dual certification option someday, and as a response to the need that we have right now. So I would support that. I think it's interesting. I think that conversation should certainly be had.
Absolutely. And just for curiosity's sake, what organizations and or environments would you foresee those specific roles being in? Of course, it could go into long-term care facilities, but based on the outlook of your role as occupational health and what that looks like and whether or not there are shortages, what other health organizations or non-health organizations would you foresee that in?
I think I could see it. I could see that working well in schools. I could see that working well for people in leadership positions in healthcare organizations as well, to manage or run both of these programs and align them a little bit closer. I certainly see that the possibility in smaller organizations as well, like we discussed.
Thank you. Thank you so much, Allison. Well, it's been a pleasure having you on the show and sharing your knowledge in occupational health. I thank you and appreciate you so much for your time.
Thank you so much,
Allison. Thank you. I'm going to remember when you said dig into the overlap, and I, want to encourage IPs to really connect with their occupational health people within their facility, because I think together we really can forge that strong program that you were describing. And really thank you for your thoughtful answers and spending time with us today.
Thank you so much.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.